So just before we start, today's talk is very much aligned with a couple of our Masters programs that we run here at SHAR, particularly our Masters in Clinical Research and also our Masters in Public Health. All of SHAR's Masters programs have a really strong focus on research and research methods. It's in the nature of obviously what we do at SHAR with the School of Health and Related Research. And you can find out more about those two programs at the link, and I will post these in the chat box in a moment. We do have some upcoming short courses at SHAR as well. Again, I'll put the link in the chat box to our short course webpage. The first two on this list are coming up in February, so advanced simulation methods and real world evaluations. We're running all of our short courses online for the time being because we're finding it's working really well and it's just more convenient for people. The latest episode of SHAR's Communicable Research podcast has just been released last week. This one is about advanced practitioner roles within the NHS, and then again a good link with this week's topic around emergency medicine. So if you want to listen to the podcast, there's 7 episodes, I think this is number 7. Andy will correct me if I'm wrong. You can listen on Spotify, on the Apple Podcast app, on the Android native podcast app, or pretty much any podcast app. If you just search Communicable Research Podcast, you will find it. The latest episode is a really interesting one. And then our next masterclass in February is with Professor Nick Latimer. We had to change that slide very recently because he's just been made a professor. But Professor Nick Latimer is going to be talking about fact or fiction, estimating the comparative effectiveness of cancer treatments using UK registry data. So another very data-focused topic next time. But today we have Professor Suzanne Mason, who's going to be talking about undertaking data-centric healthcare research, experiences from urgent and emergency care systems. So I think I've known Suzanne the whole time I've worked at SHAR. I think she joined just before I did, but we've both been there a long time. Suzanne qualified in medicine from London University in 1990 and eventually specialised in emergency medicine, spending a year as a Royal College of Surgeons Research Fellow and receiving an MD while she was undertaking higher training in emergency medicine. She's been at the university since 2001 and a professor since 2010. I remember very well when you were made a prof, Suzanne, because that was a huge big deal, the first UK prof in emergency medicine, female prof in emergency medicine, and splits her time between SHAR and her role as an emergency medicine consultant at Sheffield Teaching Hospitals. Her main research interests include evaluating complex interventions in emergency and urgent care, and she's particularly interested in the evaluation of new roles and alternative pathways of patient care. So at that point, I'm going to hand over to Suzanne. I'm just going to switch the slides over. Just give me a moment. Okay, so I'll hand over to you, Suzanne.
Thank you, Claire, and thank you for inviting me to speak today. It's a great pleasure to join everybody and from my kitchen. And I'm really hoping that you find this an informative and interesting presentation. I think the landscape of health research is changing, and what I'm hoping today that we can start to think about is how we can use routine data to help us deliver better health data research. So I'm going to give you a few experiences that we've had as a team in gathering routine data and starting to analyse that. We've got a long way to go, but I'm hoping you find this interesting and that we can have a discussion at the end of it about next steps, really. So first of all, as most of you will know, I am definitely not a data scientist. My interest in how we use routine data really comes from, I guess, my clinical background and my desire to try and improve patient outcomes and improve the delivery of care for patients, particularly in urgent and emergency care settings, but I think across the whole health and social care patch, really. And what drove the initial interest in this was the fact that, you know, we shouldn't see ourselves as working in isolation in certain departments or specialties, but we should see ourselves as working within a whole system. And in order to understand that system, we need to be able to join up the dots between the different boundaries that exist within the system. This The work I do is definitely also not in isolation, but transcends a lot of different boundaries and involves a lot of different people. And this is just some of the team, the key players in the team really, who have been able to deliver what we've managed to deliver over the past few years. So this is not about me and what I've been trying to do, but this is about a joint effort really with this team, who are an amazing group of people to work with, and I'm eternally grateful for having the opportunity to be able to work with them. So first of all, why do we need data for research? Well, we all know that we need data for research, obviously, but one of the challenges I think that we face when we're trying to represent the whole population is that some of the data we collect is limited by the nature of the people who volunteer to participate in research. And I think we know, and if the pandemic's taught us anything, it's taught us many things. It's that often the people who participate in research are not necessarily representative of the population at large, and that they are often the people who are hit by disease burden the greatest and deprivation the greatest are often not those people who participate in the research that we undertake. And therefore, in order to reduce inequalities and represent populations better and deliver outcomes that actually address those populations, we need to really be able to develop techniques for gathering data that actually represents them. The other thing that routine data provides us with is some economies of scale, and in a world that's becoming ever more costly and expensive generally, but also in the field of research, ways that we can deliver more efficient designs and we can deliver analytics in a more efficient manner should be welcomed, and we should be aiming to try and use those methods more appropriately. Finally, this is definitely the direction of policy. I think as a school, as a university, and as a group of researchers, we need to be aware of the policy direction and the funder direction, and we need to be able to tackle head-on where the opportunities for funding are and how we can capitalise on those. So I've listed there just a number of reports, a few of them. There are numerous reports coming out that talk about routine data, talk about harnessing that for the benefit of patients and the public. And this is what I guess we've been trying to do in our team for the past few years, really. So what is it? Well, many of you will know, but just in case you don't know what big data or routine data is, there are different types, and this is just an example, this table, of the different types of routine data. Mostly today, let's see if I can get the cursor to work. Yeah, I'm going to talk about mostly administrative data. But there's the potential for administrative data, which is basically data that comes from patients who attend the healthcare system. And a good example of this is hospital episode statistics data, or HES data, or the data that we get from NHS Digital. But there are all sorts of other types of routine data that's generated routinely as part of health and social care delivery that we can collect and also link in to each other. So I've sort of talked a little bit about the benefits and the challenges of research with big data. And there's some more of those challenges and benefits listed here, really. I think in terms of the challenges, we still have a massive problem in accessing data, and I'll come back to this later in the talk. But whilst data is technically available, and the pandemic again has facilitated the speed at which we can get hold of data through improving the permissions and actually sort of making it much more accessible to researchers, particularly for COVID purposes. There are still a lot of hurdles and hoops to jump through if we want to access routine data. And some of this is perfectly reasonable and for governance and security purposes, but it also can be a very slow and clunky process and quite difficult for researchers to navigate, particularly if you're a PGR student and you want to get hold of NHS digital data. It can be quite difficult. The other problem with this data is that it's generally not generated for the purposes of research. So it's not as if, you know, we've set up a spreadsheet and decided what questions we want to ask our participants, and then we're going to collect that data from them. This is all data that's collected for the purposes of a different reason, which is managing a health care situation. And therefore it's often not very clean. There's a lot of missing data. It's not been coded in a very standard way. And it often addresses a slightly different question to the one that we might have. We also need to be aware that when we are gathering routine data, we need to have the ability to securely store that data, to access it securely. I'm sure you've all done your governance training, but to make sure that we are being extremely responsible in how we handle that data and how we share it with each other. And this is where we often get a bad press as researchers, and therefore it's important that we pay huge attention to being very serious about how we handle that information, which is very sensitive, and you know, in theory, patients can be identified from it. But the benefits, as I've already talked a little bit about, are that this is cost effective. We can address multiple questions with one set of data, which I'll come on to. We can link different data sets together to answer other questions. And we can also repeat analyses. So we can look at how we can repeat analyses over time to look at changes over time or changes after different interventions have been introduced without having to go back and recollect the same data again. And we can also share the methods that we use for analysing the data so that we can expand and gather greater benefits from analysis by applying them to other similar routine data sets. How do we get hold of this data? Well, there are lots of different sources of it. We can go directly to the healthcare providers and ask them for the data, and many of us will have done that, either through getting appropriate ethical approval or through setting up data sharing agreements to access data. We can go through NHS Digital, which would mean filling out a DARS application, which can be quite lengthy and a slow process, but once the data arrives, you know, it's often very rich and there's lots of it. We can go to other organisations who already do this, such as registry data like the Intensive Care National Database, the Trauma Database, or other data banks like SAIL, Pioneer, and Discovery, which all have routine data available for researchers. The other one that you may have heard of is Open Safely, which was set up just before the pandemic and has played a key role in some of the research undertaken throughout the pandemic. Often this requires ethics and governance approval, and Section 251 through the Confidential Advisory Group approval process would allow us to have access to patient level data, and sometimes that data can be applied for on a fully identifiable basis so that it can be linked with other identifiable data. And what do we do with it? Well, we can do all sorts of things with it, is the bottom line. Economic analyses, traditional analytics, predictive analytics, modelling, and the sexy terms for machine learning and artificial intelligence, which is really just a different type of analytics. Many different types of analyses can be done, and therefore this is why the data sets are so valuable to us. What we need is the relevant expertise to be able to deliver these analytics, and people to be familiar with how we how we do that and how they can manipulate the data in that way. So I'm going to talk a little bit now about what we did, so that you can, this is an example of what we've done in accessing routine data, but this isn't a particularly special example. It's just something that I think we decided as a team was important in trying to understand the patient journey within a system. So as many of you will know, my specialty area is emergency medicine, and I have an interest in the urgent and emergency care system as a whole and how patients navigate that system, which can be very complex. Any of you that will have tried to do it in the UK will understand it's really complex, knowing how to get into the system at the right point and get the help that you need to have the right outcome. And as most of you will be aware, there are rising demands on the emergency care system, and more patients are trying to access emergency care and struggling to do so in a timely way. And the difficulties we have with rising demand is that this then compromises performance, and you'll have seen on the news recently all the talk about ambulances being ramped, about cohorting of ambulances, about long waits for beds in emergency departments, and all these in turn affect patient outcomes and can lead to poorer outcomes and reduced survival. So what we tried to do in looking at routine data was to represent the whole system, not just parts of it, and link it together so that we could understand how the journey through the system and then what their outcomes were when they'd had contact with it. So we developed a regional database for the whole of Yorkshire and the Humber, which is a population of just over 5.5 million. And in this we included every acute hospital trust with an emergency department. There are 19 emergency departments in this region, and one ambulance service which deals with all the 999 calls and the NHS 111 telephone helpline service as well. We thought we would try and collect data from these organisations and then link it together. So the data set that we set out to develop initially spanned a 6-year period from 2011 to 2017, and we linked together these services using identifiers for patients. So where we could, we linked using their NHS number, but where we couldn't do that, we linked using their other identifiers such as their name, date of birth and address. And we had approval to do that through the confidential advisory group application that we made. Altogether, we've linked over 15 million episodes of care, of around just under 30 million records. And this has allowed us to understand how patients use the system from the point at which they call either 111 or 999 or turn up in an A&E department to when they're discharged from the system, and that might be discharged from the ambulance, from the A&E department, or from hospital itself. And then we've used this to look at how the system works, and I'm going to give you some examples of that. The beauty of this data set that we have developed is that we could also expand this in a more bespoke manner and link in other data sets such as mental health, some palliative care data and some hospital data as well, which I'll come back to. So I hope you can see this. This is the cured data set, and largely this is Tony Stone's baby with Annabelle and Rick as well. You can see here that what Tony did effectively was bring in some data sets that we wanted to link together. Some of these are particular data sets, like the mental health one here, but some of them are the A&E and the admitted patient data, and this is the ambulance data. This was brought in across this sort of threshold of the university into the university system, and then what happened here was that the patient identifiers were removed from the data to form these clinical data sets, and then the patient identifiers were used to link the data sets together so that we could then develop our cured research database. The cured database is available as a research database, so we applied for approval from the National Research Ethics System to have this approved as a research database, the advantage of which means that we can use it for lots and lots of different reasons. We don't have to do it on a per project basis. So we have a fairly broad remit around urgent and emergency care service improvement, and that means that lots of different people can apply to use our data set and use it for different reasons, really, without having to go through separate ethics approval. So the ethics approval we have for this data, it covers all of these projects, provided our small subcommittee that runs within SHAR feel that it fits within the remit that we have approvals for. The access to the cured data is on virtual machines, and anyone accessing the data has to have the appropriate training and level of permissions to be able to see the data. And then Tony and his team help us to prepare the research data required by each individual researcher so that they can then analyse it. So what are the kind of things that we've done with the data? Well, as I said earlier, what we wanted to understand was how patients experience healthcare within this system. So we've started off just by looking at who attends the emergency department and when they come, and you can see from this pattern that attendances at all the emergency departments in Yorkshire and the Humber is exactly the same, and that there are two peaks of attendance, one in the sort of late morning, early afternoon, and another one in the early evening going into the night time. And this is the same every day, every week. It just varies in terms of how busy it is. So Sundays and Mondays typically are busier days. Monday's the busiest day of the week, and then it tails off towards the end of the week, and then it builds up again over the weekend. And that's the same everywhere. So when we have policymakers telling us that they can't predict who's going to attend an emergency department and when, that is simply not correct. The second thing that we then looked at were, can we apply different algorithms to look at certain groups of patients within the system and try and understand how we could manage those patients differently? So this is a paper that we published quite early on when the data set was developed. When we looked at this definition here of what we call an avoidable emergency department attendance, this definition was first developed by John Nichol and his team, and they defined what would be termed as an avoidable emergency department attendance. This is effectively somebody who comes to the department and doesn't really have anything done, apart from possibly having their urine tested, which we think could be done in other settings, and that they don't get any treatment apart from a prescription, which they could get in another setting, and that they then get discharged from the emergency department. And we mapped this onto our attendances. So this is all the attendances, the previous slide you saw, and below are the avoidable emergency department attendances, and you can see that they have a slightly different pattern of attendance compared with all patients. Again, still busier at the either end of the week, but they tend to be, the avoidable attendances tend to occur more into the evening and night time than the non-avoidable attendances. When we looked at this in terms of numbers, 23% of adults have an avoidable attendance at an emergency department, and this is around 20% of children. So these are high numbers, and if we could remove these from emergency departments and have these patients seen elsewhere, or indeed not at all, then our demand would improve, our flow would improve, and therefore our ability to treat patients in a more effective way would improve, because staff workload would go down. We know that these patients tend to be young adults. They tend to be less than 45 years old, and this information therefore can be used to understand how we could manage this type of demand differently, and what other settings might be appropriate for doing that. We did the same with avoidable ambulance journeys. So we looked back and said, well, of those patients who come to A&E by ambulance and have an avoidable attendance at the emergency department, who are they and what do they come by ambulance with? And this work was done by Jamie Miles, who's one of our PhD students. And this is effectively a heat map. On the left of the heat map, you can see the total numbers, and on the right, you can see the proportions of those patients who call an ambulance and then turn up at the emergency department and basically don't need to be there, don't have anything done. And as you can see, the numbers and proportions are highest in certain types of conditions, such as breathing problems, fits or seizures, mental health problems, and interestingly here at the bottom, referrals from other healthcare professionals. So our other healthcare professional colleagues are fairly high users of ambulances that then turn out to have a completely unnecessary attendance at the emergency department. The largest culprit being the 111 service, which actually sits within the ambulance service. And if we look at this, around 1 in 6 ambulance conveyances in 2014 were completely avoidable. That number will be much higher now. And if we look at this down here, for example, we can see that in the under 54s, in 2014, around 22 journeys a day were avoidable that were made by other healthcare professionals. So there's a certain amount of education needed, or better systems needed, to refer patients from other healthcare settings that don't need an ambulance response, which I'm sure you agree is expensive, but also a precious resource. And if we distill this down a little bit further, the number for avoidable conveyances by ambulance out of hours goes up to around 1 in 5, and 1 in 3 of these of the patients having avoidable conveyance under 35, it is a really high number of patients who are young using ambulances and then coming to the emergency department without having anything done. And when we look at the big 5 potential targets for intervention, we find that there are some culprits that many of us won't be surprised by, but I guess what we need to look at is what would be the alternative solution for these patients. We were the first people to link data from the 111 service to emergency departments. So 111 were able to describe what the call handlers taking the calls told patients to do, but what they couldn't do was actually tell us what patients actually did. So did patients actually follow the advice given by the 111 service and attend emergency departments or not attend them as advised, or did they do something differently? And this paper was published by us not long ago. Jen Lewis did most of the work on this. And as you can see, the 111 service basically services a very low acuity set of calls from patients. Most of them are actually referred to self-care or primary care or community care rather than to an emergency outcome. Of those who have an ambulance called for them, only 70% of those get sent to the emergency department. So 30% of ambulances sent by 111 actually don't get, the patients don't get transported, which is a huge waste of resource. And then when we look at those who are told by 111 to go to primary care, around 10% of them don't do that. They go to the emergency department. And these numbers are quite significant and quite high. And again, if these were not turning up in our emergency departments, then you know, it would have a huge impact on the workload and our ability to treat those patients who do genuinely need to be there. We're just dabbling at the moment with a little bit of machine learning and artificial intelligence, and this is one example where we're using working with computer science to undertake some data visualization techniques to understand flow in the ambulance service. Again, I don't expect you to be able to really read this slide, but this just shows you what the computer scientists have been doing with the data to develop these clusters. And each of these little rows of bars is a different type of patient and a different type of call. So the visualisation techniques can be used to understand flow through the ambulance service, and where there are particular clusters of patients that could be amenable to a different outcome or a different response. And we're hoping to build on this pilot work really to try and understand how this can help us to identify where we might have the greatest impact with different outcomes for which groups of patients. Chris Burton's done some great work looking at frequent users of emergency departments. These are patients who attend frequently. And what he was interested in was looking at whether this was actually a problem with the system rather than with the patients themselves. And he was right. So if we look at these charts, you can see that what Chris did was try to treat the emergency care system as a complex system, which we know it is, and to see whether frequent users are really a function of that complex system rather than at a more individual level. So we can see here that high use goes down. So the numbers of patients using departments frequently goes down, so there aren't many using it very, very, very frequently, which is to be expected. And if we break this down by deprivation and different age categories, you'll see that they have the same pattern with some variation depending on that level of deprivation and the age. But what we notice from this is that every department has a similar pattern, and this isn't therefore dependent on the individual, that each frequent user, as they change their pattern of use, they're often replaced by a different frequent user, which reflects the fact that this is a problem with the system rather than at the individual level. And that if we tackled frequent use of services at a system level, this would help us to reduce it overall. As I mentioned earlier, one of the flexibilities of our cured dataset is that we can link in other datasets. So we've done some work with the Sheffield Health and Social Care Trust with Scott Weish, linking in mental health trust data to understand how patients with serious mental illness use emergency care and when they use it, and whether this is a signal that their current management is failing, such that they're coming to some point of crisis and need to attend the emergency department. We've worked with Paul Taylor and some of his palliative care colleagues in the St Luke's Hospice to link their data with our data to understand what's happening with patients who are near the end of life. And finally, we've also linked with the neurology department at the Sheffield Teaching Hospitals to understand how patients with a functional neurological disorder use emergency departments and whether treatment of those patients can actually reduce the use of emergency care. Just as an example, what Paul Taylor found with palliative care patients is that most of them don't actually have any contact with the emergency department in the final year of life, which is great, but unfortunately a significant proportion have some contact even in the last 30 days of their life. I'm sure you would agree that coming to an emergency department is not ideal in the last 30 days of your life. And I think understanding something about who these people are and why they are slipping through the net and how palliative care can be improved to address their needs better would be hugely beneficial to them. I want to move on now and just talk a little bit more broadly about routine data in the future. And first of all, just to highlight, some of you will know about HDR UK and indeed will be part of it. But HDR UK was originally set up by the MRC and it's funded by a number of different funders, including mainly MRC, but also the NIHR and a number of other organisations. They recognise the need to drive the agenda on how we use routine health and social care data to improve research and outcomes within the UK. And about 4 years ago now, they set up HDR UK and funded a number of different strands of work within that, and that was mainly relating to research hubs here, training, and research locations. The University of Sheffield became part of HDR UK North, and myself and Peter Bath and Chris Burton and a few other colleagues are part of HDR UK North, delivering research for the University of Sheffield that has a strong data focus. HDR UK is very ambitious to grow health data research within the UK. If I'm honest, I'm a little unclear how well that's going at the moment, but they are looking for another 5 years of funding, and I think it would be great if the University of Sheffield could be part of that on an ongoing basis. So what is HDR UK North? Well, it's a collaboration between the NHS and academia, serving, as I said previously, a highly deprived population with some of the worst health outcomes across the whole country, and therefore we are very keen to deliver health data research that improves those health outcomes. As part of the funding that we got for this, so we had 3 attempts to become part of the HDR UK family, and on the 3rd attempt we were successful. So it was not an easy fight. They were very reluctant to fund anything north of the Watford Gap, and in the end we managed to persuade them that this was something that was of benefit. So what they funded us to do was a series of projects, and you'll see here there are 3 main projects and then some cross-cutting themes. I am leading the Learning Care Homes project, and Peter Bath is leading training and capacity building projects across the whole of the 3 projects that we are delivering. And the other 2, the anticholinergic work is being led from Leeds, the Better RX is being led from Manchester. What's Learning Care Homes? Well, this brings me, I guess, quite neatly on to social care. Social care, there's a massive routine data void in social care, and this is going to be one of the biggest challenges, I think, facing us in the next 5 years. I think healthcare data is relatively well curated. It's fairly available to researchers. Social care is a complete black hole at the moment. Local authorities and social care don't even understand the data that they hold. There's no standardization of that data, and that is very difficult to get hold of. They're not used to dealing with researchers, and they often have difficulties in understanding the governance surrounding it. So we started this project, which was really around evaluating a technology that was being used in some care homes in the northeast to try and improve the referral of residents in care homes to who develop an urgent problem or an emergency problem. The idea is that they use an app rather than a telephone to make a structured referral of a resident who's become unwell, and that gets processed. Information gets processed in a hub, and then a decision is made after consultation with the records that are available from the patient on what to do with the resident. And then the care home is informed of the outcome. The idea is this is more efficient, it saves time because the staff don't have to sit on the phone trying to get hold of a GP, and that the idea is that they will have a more efficient experience closer to where they live rather than having to go to the emergency department all the time. And so our evaluation set up to collect data from a number of care homes and link it with A&E and admissions data. But the challenge is that the care home sector is often very reluctant to share data, and the process in trying to get hold of that data and then link it with our data has taken us about 18 months. So it's certainly not straightforward. However, we do have a complete data set now. We've linked together 10 different data sets, some of which have come from local trusts and some of which have come from care homes and from the apps that they're using. And you can see here just the extent of the data is quite huge. The analysis is being led from Lancaster, University, and they've done a fantastic job linking it all together. And then SHAR will be leading on the economic analysis, which is being led by Simon Dixon. In conjunction with getting the funding for HDR UK, we also applied for one of the sprint bids around the pandemic and were successful in getting some UKRI funding to look at the changes in referral practices within care homes. And this project is just about coming to an end now, but we've evaluated the pandemic period in about 120 care homes to look at the flows of patients in and out of care homes and try to understand how much that may have influenced mortality within care homes related to the pandemic. This is just information, so this is just telling us how often the app is being used in care homes, and we just got this from the link data that we're using. And then again, from the link data we can understand, this is just a sample of our patients, it's about 100 patients in here. We can understand the journeys that they take from the moment that they're referred through to the black lines, which unfortunately is death. So coming to the end of the talk now, I've just got 2 or 3 more slides. My passion now is around how we can harness and use routine data to deliver better research to improve population outcomes. And we have to make this our comfort zone. You know, we have to become familiar with this, and we have to become, it has to become second nature to what we're doing in research within SHAR, I think. We have to be able to chase the right funding opportunities, of which there are many, and unfortunately we haven't been able to make the most of those funding opportunities as a university. We need to make good connections with academics in computing and engineering, and again, we haven't done that very well in SHAR, and I think there's a lot more scope for that moving forwards. And we also have to make good connections, which we are good at, with our stakeholders in the community, with the NHS and with social care. Better ways of accessing health and social care data are essential, so that we aren't doing this on a per project basis, but we actually have systems set up that are robust, that are doing it for us, and I'll come on to that in a second. And then we need to be able to use the expertise that we have in some of our fantastic data managers and data scientists, but also to retain these people. Unfortunately, the private sector is all too willing to pay a handsome salary to employ some of the fantastic skills that we have across the university, and we need to incentivise these staff to keep hold of them. We need to be able to take the public with us on this journey, and understanding their perceptions and their understanding of what it means to share data for research is really vital. And then to really look at where the opportunities are in terms of impact and delivering the kind of links with clinical care that we need to. So what's the future for Cured? First of all, as you will have noticed if you were listening, the data set actually that we have is a complete data set, but it finished in 2017, so it's already getting a bit out of date, and we would like to update that. So we're in the process of expanding and extending the data set and bringing it right up to date. But developing the Cured data set took us about 3 years. So it is by no means an easy thing to do, and it's not something that I would want to keep doing, to be frank. We're applying for an updated data set at the moment because we have more funding that we need to be able to deliver data for. But the method we're using this time is changing slightly and is expanding. So we will have a national data set of emergency and urgent care that will span emergency departments and also walk-in centres and urgent care centres. That will be linked with admissions data, outpatient data, and some mental health data. So that will give us a much, much richer data source. We are also including in that death data and medications data, which will be really, really helpful in understanding the comorbidities that some of these patients have. And then finally, we are going to retain the regionality by linking in the ambulance service data back on a regional basis to give us that Yorkshire and Humber system-wide feel. This is being done by NHS Digital instead of being done in-house at the moment. On a university level, if this has taught me one thing, it's that we need a better way of doing this as a university, because at the moment we are all doing this in our little silos. We don't have the capacity to do it, we don't have enough staff to do it, and it takes up a lot of researcher time that probably it shouldn't, because it's not really a researcher job, it's more of a technical job. So on the left of this slide, these are my experiences of curating data. And on the right, this is where we need to move to. So at the moment, we are negotiating with the university about how we can develop a hub that's going to provide support across the whole university, faculty-wide, where we can service the need for routine data and develop the skills in-house that allow us to do this on a much more timely in a much more timely manner. That will hopefully be more cost effective, but also save researchers a huge amount of time. I'm happy to answer any questions, or if you'd rather email me, that's absolutely fine. I hope you found that informative, and thank you for listening.
Okay, thanks for that. I'm going to work backwards through, because we have had some questions. Okay, I'll go with the last one first. So Tim asks, he says, great talk, and then asks, is accessing primary care data through NHS Digital still a barrier to your research?
Yes. So through the COVID rules, we technically can have access to some primary care data, but if the COPI rules, they're called COPI rules, if they don't get extended, which they may not, then that won't necessarily be as easy. And so at the moment we have not applied for primary care data under the COPI notice, because we're not, we don't know that it's going to be extended. We're looking at ways to access primary care data on a more regional basis at the moment, which I think is probably the way to go, and then link that in with secondary care data. It's a massive black hole, and there is massive issues with primary care not, unfortunately, primary care sometimes think it's their data and it's not their data, but they're not very keen to share that data often. So I think there's some work to be done with primary care in trying to understand the benefits of doing that.
Okay, there's a question. Okay, there's a question from Anna. It says, do you foresee any issues in terms of implementation or education? I'm guessing, did you mean that in relation to Cured Plus? I'm not sure. You might want to clarify that in the chat box, Anna. I think while we're waiting, there's another question from Dr. James Gray, who says, my research focus is clinical reasoning, and a major area is context. It's very difficult to research, but crucial in decision making. How do you think we use this data to help us target research to understand the context in which HCPs make decisions to send to the ED? At a personal level, the lack of appropriate mental health support, for example.
Yeah, I think that's really fascinating, James, because of course I guess the thing that this doesn't do is help us to understand what's driving decision making, and clinical decision making is crucial to everything that we do. And so I think there are two aspects of that. One is if we can understand how decisions are being made, and part of that is a separate research question by doing qualitative research with ACPs or doctors or whomsoever, which with another hat on I also do a bit of. But the other part is they're able to access things like electronic patient records. And so I think as time goes on, we will be including, where possible, electronic records so that we can try and use techniques such as natural language processing to help to understand how decisions are being driven. And certainly at the moment, the ambulance service, as you will know, James, have got electronic records, and that in our new refresh of Cured, we will be including electronic records in that. And I think that will help us. The second thing is how can we manage decision making better, or help people make better decisions? And I think that can partly be done by using machine learning or artificial intelligence techniques to add in decision support tools to software that help to guide clinicians in terms of what the likely outcome of their patient will be. And I think the power of some of the data that we hold will help us to be able to predict whether patients need admission or not, and that in turn can help people who perhaps are less confident in making those decisions.
Okay, thanks for that, Sue. I can see Amna's responded. She says, while it would be really helpful in emergency departments to be able to reduce unnecessary admissions, I can imagine it would be difficult to get this implemented within the 111 service and difficult to educate younger people about the appropriate services to contact rather than calling for an ambulance.
I completely agree. So for me, this is the long game. I think at the moment, it's quite easy to call an ambulance and get a response. And I think what we need to do is make that the harder option for certain people who don't require an ambulance. And there are lots of different ways that we can do that. But one of them is by giving the 111 service a better set of options, of referral options. And in many places around the patch, there often aren't those options available to a 111 call handler. But the other thing is, by having better decision support software for 111 call handlers, they can be able to dispense more confident advice and signpost more confidently. At the moment, the algorithms that the call handlers use in the 111 service are very unscientifically developed. So I think a better approach to that would be a much more robust way of managing the quantity of calls that they get.
Okay, we had another question. John Stady asked, do you have any thoughts on what might be needed to address the social care data issues?
I think in short, integrated care is going to mean that they have to do it. So I think because of the changes that are coming in April, with integrated care systems being responsible for the delivery of care, health and social care across a population, I'm hoping that that will drive the need for us to harness social care data and to be able to use it more effectively. At the moment, there isn't that need there. I think there's a long way to go, because in many ways healthcare data is way ahead of social care in terms of just understanding what we call the metadata. So, you know, which John will know what that is, but a lot of you may not, which is just knowing what's there, what the fields are, what the items are that are collected, and how we standardize that. So there's a way to go with that, but I think partly it will be driven by integrated care systems.
Okay, and one last question from Mel. Mel asks, will Cured Plus only link with Yorkshire Ambulance Service EPR or all ambulance trusts EPR?
Well, I'd love it to link with every ambulance service, but I just don't think we have got the capacity to be able to do that. So that's a huge job, which would mean us working with, because ambulance data isn't collected by NHS Digital, we would need to go out to every individual ambulance service and ask them if they would share data with us. And I said earlier that took us about 3 years to do that before, to develop our Cured data set. And I just don't think we have the capacity to be able to do that. So what we're doing at the moment is sticking with the Yorkshire Ambulance Service and then possibly growing it from there. See how we go. I think you're on mute, Claire.
Sorry, I've got 2 different mute buttons. Shake myself in the foot. Thanks everyone for joining us today, and thanks hugely to you, Sue, for that really, really interesting presentation. I think it speaks a lot to me and Andy, as well as informatics interested people. Thanks to all of you who joined us today. We put all the links I think that you'll need in the chat box earlier on in terms of sort of staying in touch with us. And obviously do join us in February for Professor Nick Lattimer's talk, and hopefully we'll see you then. But thanks for joining us, everyone.